Okay, so welcome back to part 2 of our lecture on the male reproductive system in our human disease states lecture. So going back to the question, what was the problem of this patient? So this patient had a ventral opening on the penis, which was supposed to be the urethral orifice, so it was not on its normal position. So this was due to the failure of the urethral folds to close. So these are developmental abnormalities which can actually lead to problems in the male reproductive system. So what are the other congenital malformations that are commonly associated with the male reproductive system? So we have your gonadal agenesis, which basically means the failure of your primordial germ cells to form in the first place, or even to migrate from the GI tract to the gonadal ridge. So without your primordial germ cells, of course, you will not develop any gonads, and subsequently you will not have any male reproductive organs. You also have your hermaphroditism. Hermaphroditism can be true or pseudo hermaphroditism. So when you say true hermaphroditism, it simply means the presence of one ovary, one testis, or the absence of external genitalia, both genders. Alright. So if you have just a presence of one ovary or one testis or external genitalia, both genders, then you have what we call true hermaphroditism. Pseudo, on the other hand, is the presence of the gonads, or let's say a karyotype of one gender. Let's say you have your internal genitalia of either male or female, and then this is combined with secondary sex characteristics of the opposite gender. So for example, if you have a female gonad, you have ovary, you have fallopian tubes, however you have a penis, that is an example of pseudo hermaphroditism. So you have opposite combination of your gonad and karyotype with your phenotypic characteristics. So in the male, which we call male pseudo hermaphroditism, you have testicular feminization. Meaning to say, you are male in terms of your gonads and your karyotype, but your external genitalia, you don't have any male structure, you don't have your penis, or you don't have a testis. It is called male pseudo hermaphroditism. On the other hand, for the female, if you have female pseudo hermaphroditism, this is basically due to adrenogenital syndrome. So you have a female gonad and karyotype, but you have, let's say, a male genitalia externally. On the other hand, your cryptocardism is the failure of the testis to descend from its normal, its intestinal location down to the normal location in the scrotum. So your undescended testis usually migrate to the scrotum within 3 to 6 months of birth. And you might see this in the clinics if you palpate the scrotum of a child, and if you feel it's empty, then you'd suspect that the child have undescended testis. and it's called cryptorchidism. Congenital inguinal hernia, on the other hand, is the incomplete closure of the inguinal canal, which allows for abdominal content to pass through to the scrotum. So this is due to an incomplete process of closure of the inguinal canal. So this is a potential for herniation. It needs to be corrected by surgery. Hypospadias, on the other hand, are abnormal opening of the penile urethra on the inferior side of the penis. So this is secondary to failure of the urethral folds to close. So this is our case earlier, where you have a male who have a ventral opening on the penile shaft. So this is secondary to urethral folds closure, failure to close. This is very common, in fact most common penile disorder, hypospadia. Opposite to it is your epispadias. Epispadias are marked by an abnormal opening of the penile urethra on the superior side of the penis. So this is secondary to malpositioning of the genital tubercle. So this is associated with exestropy of the bladder. So this is in opposite to your hypospadia. So that is in terms of your embryological development. Now let's take a look at your anatomical structure of the male reproductive system. And if you take a look at the structures located within and outside the pelvis, you would know that they pass the sperm passes through several pathways to exit the body. So from the seminiferous tubules, it goes to your epididymis, then to your vas deferens, then to your ejaculatory duct, and then it passes to your urethra, then to your penis. So any problems along these structures will affect the exit of the sperm from the male, so that it will lead to problems of reproduction. Looking at your male urethra is composed of several structures. One is your prostatic urethra, and your membranous urethra, and your spongy urethra. Your prostatic urethra is the widest portion of your urethral structure, and then it crosses over to your urogenital diaphragm and your external urethral sphincter to become your membranous urethra, and then the membranous urethra becomes your spongy urethra, which is the longest section of your male urethral structure. So any abnormality within these structures can lead to problems, not only in terms of reproduction, but even in the normal discharge of your urine. Okay. Your spermatic cord, on the other hand, is composed of your vas deferens, cremasteric muscle, testicular artery, pampiniform penis plexus, genital branch of the genitofemoral nerve. And damage to your spermatic cord can damage all of these structures contained within the cord. And running along the top of your spermatic cord is your ilioinguinal nerve, which is also a very important innervation for your genital structure. Your scrotum also has several covering, including your tunica dartus, which is superficial to your collis fascia, and of course you have your gubernaculum, which is a scrotal ligament. So if you go into surgery department and you operate on a male with testicular problems, if you dissect the scrotum, you would see that there are several layers by which you have to go through to gain access from the skin, you have your dartus, which is a thin muscle, over your external spermatic fascia. Then you have your cremasteric muscle, which is the source of your cremasteric reflex. And then you have your internal spermatic fascia. And with that, you have your tunica vaginalis. And covering your testis is your epididymis. And finally, you have your testis. So these are the several layers within your scrotum. If you take another look at your penis, cross-sectional look or view, you would notice that there are several tubular structures within the penile shaft. You have your corpus cavernosum containing your cavernous artery. So you have two corpus cavernosum, and of course lying on underneath you have your corpus spongiosum, which contains your urethra. Then the superficial dorsal vein was the topmost portion of your penis, covered by your areolar tissue above your deep fascia. Of course, it is underneath your skin and underneath your superficial fascia also. And of course, your tunica albuginea is the one that contains your vascular structures, including your deep dorsal vein and your two dorsal arteries. Any damage to this section can affect several blood vessels and even affect your urethra, leading to problems. So taking a look at your spermatic cord derivatives of your abdominal layer, you would see that the equivalent structure of your abdominal structure with the spermatic cord are the following. Your external oblique muscle aponeurosis is related to your external spermatic cord. Your internal oblique muscle is related to your cremaster muscle. Your transversalis fascia is related to your internal spermatic cord. Your extraperitoneal fatty tissues are related to your areolar tissue. Then lastly, your peritoneum is related to your processus vaginalis. What about your prostate? Your prostate has several characteristics. It has prostatic secretions composed of alkaline fluid mixed with seminal fluid and spermatozoa. Your ejaculatory duct have middle lobe, which is posterior to your urethra. So your ejaculatory duct is found in the middle lobe, posterior to the urethra, while your prostatic lobes can be divided into anterior, middle, lateral, and posterior. So you have about 5 lobes in your prostate, including 2 lateral lobes. In terms of zones, which are useful for designating areas affected, for example, by diseases or pathologies like cancer of the prostate, you have your transitional zones, zental zones, and your peripheral zones. So this is a visual representation, a schematic diagram showing to you your 5 lobes. So you have 2 lateral lobes, you have your anterior lobe, you have your middle lobe, and you have your posterior lobe. So these are the different lobar areas of your prostate. Your prostate, on the other hand, can be divided into transitional zone, a zental zone, and underneath that your peripheral zone. And you will notice that your peripheral zone is actually adjacent to your rectal wall. And when you do palpation, direct rectal examination, this is the area that is easily accessed by your direct rectal examination, your peripheral zone. and of course in the middle is your urethra. Taking a look at the basic physiological concepts associated with the male reproductive system, well, you have your gametogenesis and spermatogenesis. So gametogenesis is the formation of healthy gametes, important for sexual reproduction, so that your spermatogenesis and your oogenesis actually go through analogous stages. So for both for the male and female reproductive development, they go through the same analogous stages for the development of the eggs and the sperms. Spermatogenesis has several phases. You have your mitosis phase, you have your meiosis 1 and your meiosis 2. So during spermatogenesis, there is initial production of a diploid chromosome, and the product is your spermatogonium. So you have twice the normal number of chromatids. So then after development, it leads to your primary spermatocyte, which has 4 times the number of chromosomes. Then you go to your haploid chromosome, your haploid chromosome of 23 chromosomes. You have your secondary spermatocytes. Your secondary spermatocyte contains twice the number of chromosomes. Finally, it divides into 2. You have your spermatid, which has the usual number of chromosomes of 23 chromosomes. Then finally your active spermatozoon. So let's take a look at spermatogenesis. So spermatogonium has twice the number of chromosomes of your gametes. So you have a diploid number, so that's about 46. So by mitosis, it reproduces itself, spermatogonium. Then when it goes to meiosis, so it has to divide. So this one, your primary spermatocyte, it multiplies itself. It becomes a diploid 4N gametocyte. Then through meiosis 1, it divides into 2 secondary spermatocytes containing haploid number of chromosomes 2N. Then meiosis 2, it will further divide and separate the genetic material into 2, so that you have out of the original 1 primary spermatocyte, you produce 4 spermatids with the usual number of chromosomes N, which equals to 23. And finally it becomes activated, it develops into a mature spermatozoon, which now is capable of fertilization. So this is your mature sperm, which is a tail, a middle piece, and a head. So you will notice that the genetic material, of course, is found in the nucleus, and the genetic material is found in the head. However, your middle section contains the mitochondria. So the mitochondria actually also contains several genetic materials, and this is your tail, which is responsible for the motility of your sperm. So what is the function of your Sertoli cells in spermatogenesis? It acts as a barrier, so it's a blood testis barrier which prevents admittance of noxious chemicals or substances or anything that will affect the sperm, that the substances that are in the blood that might affect the sperm, so they keep out the harmful substances. It also secretes substances that aid in the process of meiosis or spermatogenesis. Then it also phagocytoses or eats residual cytoplasm left over following spermiogenesis. And of course, it secretes other factors including your androgen binding protein, ABP, your inhibin, and your giant cell line derived neutrophilic factor, GDNF, and your estradiol. So these are the cells found in your seminiferous tubules. So you have your interstitial cell of Leydig here, capillary. So these are your cell of Leydig. These are your Leydig cells. Then this is a fibroblast on the wall. Then of course you have your basal lamina here. And your Sertoli cell is here. It's found together with your spermatogonium within the luminal, within the basal compartment of your seminiferous tubules. So there is also a junctional complex composed of tight junction between your Sertoli cells. That forms a blood testis barrier. So these are your spermatogonium, and then when they mature, they become your spermatocyte, primary spermatocyte, then secondary spermatocyte, and finally, if it will become mature, it becomes your spermatids, and they will now be located in the luminal portion of the compartment. So they migrate from the wall, and then they gradually, as they go outside here to the lumen here, you have the development of your spermatogonium to your mature spermatids. And of course, your Sertoli cell comprises your basal layer, which forms a tight junction between the blood and the testis here, so that it will protect the developing sperms from outside environment. Your spermatogenesis is controlled by your hormones coming from your anterior pituitary. Your anterior pituitary releases your luteinizing hormone and your follicle stimulating hormone. Your luteinizing hormone stimulates the synthesis of testosterone in Leydig cells. So your Leydig cells then will release testosterone to the blood vessel, and then it will act distal to the Leydig cell to have a systemic effect, while your follicle stimulating hormone will stimulate Sertoli cells to produce your androgen binding protein and then your inhibin. So these are your Sertoli cells, and then your Sertoli cells will produce inhibin, and inhibin will have a negative feedback to your anterior pituitary, so that it will gradually slow down the release of FSH of your ABP and your inhibin. On the other hand, your blood vessel will send a feedback to your hypothalamus to suppress your GnRH, so that it will no longer be very active in terms of releasing your luteinizing hormone and or FSH. So that is the basic hormone regulation of your spermatogenesis. So your ABP or androgen binding protein ensures that testosterone in the seminiferous tubule is high. So your ABP ensures that there's a lot of testosterone in your seminiferous tubule, allowing for the sperms to develop normally. Your inhibin also acts to inhibit your FSH release, and your testosterone actually allows for the differentiation of your male genitalia. It has anabolic effects on protein metabolism. It maintains spermatogenesis. It maintains libido. It inhibits your gonadotropin releasing hormone, and it fuses your epiphyseal plates in the bone. So your FSH, in summary, acts on your Sertoli cells, which encourage sperm production and luteinizing hormone. Acts on your Leydig cells, which releases testosterone, and your testosterone also encourages sperm production or spermatogenesis. So taking a look at the sexual response quickly, just when you look at sexual response or arousal, it has 4 phases. One is your desire, then excitation, then orgasm, then a resolution. The function of erection is mediated by your pelvic splanchnic nerves through your parasympathetic nerves, your S2 to S4, while male orgasm, on the other hand, is mediated by your sympathetic nerves through your thoracolumbar T10 to L2, so that seminal emission and antegrade ejaculation can happen. It also your antegrade ejaculation is mediated by your pudendal nerve, S2 to S4. So what leads to detumescence is your vasoconstriction of your arteries, so that when your arteries vasoconstrict, it will lead to the decrease in blood flow through your penile blood vessels, leading to detumescence. Let's now take a look at the diseases affecting the male reproductive system. You have your genetic diseases affecting the male reproductive system. You have your penile diseases, your disease of the testes, and your plastic processes. So what are the genetic diseases that affects your testes? You have your Klinefelter syndrome, which affects about 1 per 500 to 1,000 male births. So this is not a very uncommon disorder. This is somewhat a common disorder. 1:500 to 1,000 male births. You have 47XXY, so you have a double X chromosome. So this is due to meiotic non-disjunction and maternal aging. And if you have a male with 2X chromosome, this is associated with autoimmune disorders, including your SLE, rheumatoid arthritis, and your Sjogren's syndrome. Usually, males will present with azoospermia, which leads to hypogonadism, like gynecomastia, puberty, and elevated gonadotrophins. You also have diagnosis due to the presence of gynecomastia, tall stature, and small firm testes. Usually treatment can be done using testosterone therapy. What if you have 2 Y chromosome? You have your double Y chromosome, XYY. In terms of phenotype, the external appearance, the male appears normal, and the XYY chromosome is due to paternal non-disjunction at meiosis 1, resulting in a sperm with extra Y chromosome, so it failed to separate during meiosis 1. This happens in 1 to 1,000 male births, and usually associated with risk of learning disabilities and behavioral problems. And in fact, there have been studies that show that there is an increased proportion of XYY males in prisons and mental hospitals, which have later on been proven to be incorrect. Often they manifest as taller than their parents and siblings, and they have severe acne problems. So if you're a male with severe acne problems, have your genes checked for your XYY chromosome. Aside from that, there are no other associated problems with this. Male pseudohermaphrodite is due to the fact that you are genetically male with female external genitalia. Usually the testis is present, but this is not obvious on physical examination. Basically, what the problem here is a deficiency of your testosterone. So if you have low testosterone or lack of effective testosterone, this will lead to defective testicular differentiation, impaired secretion or production of testosterone, failure of conversion of testosterone to DHT, and then you will have defect of androgen receptors. Another problem is your 5-alpha reductase deficiency, which actually is a problem related to the enzyme that convert to testosterone to dihydrotestosterone. So if you lack 5-alpha reductase, you cannot convert testosterone to DHT, and since DHT, which is a potent androgen, is required for male external genitalia to develop, then what happens is you will have a testis but with a female or ambiguous external genitalia. So you have internal genitalia which basically is male internally, but externally there is ambiguous male external genitalia or a female external genitalia. Androgen insensitivity, on the other hand, is due to a mutation of androgen receptors on the tissues. You have normal testes and testosterone. However, your tissues does not respond to androgen due to a lack of or a problem in androgen receptors. So what happens is there is failure of development of internal and external genitalia. You have complete androgen insensitivity. If you have complete androgen insensitivity, then you will have a normal female external genitalia. If you have incomplete androgen insensitivity, then you will have ambiguous external genitalia. True hermaphrodite. True hermaphrodite is you have both ovary and a testis. It's due to an XX or XY mosaicism, abnormal crossover of a Y chromosome with the SRY region to the X chromosome. So the SRY region in a Y chromosome is transferred to the X chromosome. Then the manifestation is external genitalia is either male, ambiguous, or female. The most common type of external genitalia is ambiguous. So a true hermaphrodite usually have an ambiguous external genitalia. Gonads may be compound, meaning to say it has both ovary and testis. You call it ovotestis. This is the most common, followed by ovaries, and the least common, you have a testis. So the general duct follows the ipsilateral gonad, and this is usually associated with the germ cell tumors, inguinal hernias, and obstructed genital tracts. Let's now go to penile diseases. Penile diseases are actually due to congenital abnormalities, infectious diseases, or other abnormalities. So when you go to surgical rotations, you will know that hernia, very common among children. Your congenital inguinal hernia is due to a protrusion of abdominal cavity contents into your inguinal canal through persistent processus vaginalis. And you also have your indirect inguinal hernia, which is lateral to the inferior epigastric vessels. So this is associated with the hypospadias, epispadias, cryptorchidism, and ambiguous genitalia. Usually the male to female ratio is 48:1. So this is very common among males, congenital inguinal hernia. So management is of course surgery. So other problems that might affect your penis includes infectious diseases like syphilis, gonorrhea, and chlamydia. So I will go into the details here. Suffice to say that these are all sexually transmitted diseases and can actually affect your lower urinary tract and male reproductive system, including the manifestations like urethritis, prostatitis, painless chancre on the penis, etc., etc. Okay. Let's now go to your second case of an uncircumcised 49-year-old man presenting with sudden onset of severe pain in the distal portion of his penis. The emergency room physician examines the patient and finds that the foreskin is retracted but cannot be rolled back over the glans penis. The ER physician calls the urologist who performs an emergency resection of this patient's foreskin. Which of the following is the most likely diagnosis? Balanopostesis, titis, epispadias, omphalocele, paraphimosis, phimosis. So, what is the most likely diagnosis? The problem is an uncircumcised male is presenting with severe pain in the distal portion of the penis. Foreskin of the penis is retracted but cannot be rolled over the glans penis. So what is the likely diagnosis? We'll come back after you have thought about